Welcome everyone to the April 2020 edition of the Pre-Hospital Care Research Forum Journal Club podcast. We're very happy you can be here. Just as a reminder, the Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. And we believe that it's the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. And so here at the PCRF Journal Club, we take a closer look at some of the latest research that's happening in EMS. I'm Remley Crow, and today I am joined by Dr. Tony Fernandez and Dr. Bill Toon. We are also really excited to have some special guests here with us who authored this paper, Dr. Sheldon Cheskes and Dr. Ian Drennan. And as a reminder, the name of the article that we are reviewing is Double Sequential External Defibrillation for Refractory Ventricular Fibrillation, the Dose VF Randomized Controlled Trial. That is early view online in Resuscitation. So this review is paired with an article written by columnist Dr. Tony Fernandez in EMS World. It's called Journal Watch. We encourage our listeners to check out this article at emsworld.com under the category of Education and Training. And before we kick off, I want to thank you all again for joining us. We want to remind you that you can use the chat feature on your screen to type in questions and comments as we go, and we'll be bringing those into the conversation. So please use that chat feature. And with that, I would like to extend a warm welcome to Dr. Cheskes and Dr. Drennan. Thank you all so much for taking the time to be here and discuss your great work with us.
Hey, he's really happy to be here.
My pleasure.
Well, before we get into the paper, I think it would be really great for the audience if you authors could take a moment just to introduce yourselves, tell us who you are, where you work, your favorite breakfast cereal, you know, the usual questions. We can kick off with Dr. Cheskes if you like.
Sure. Yeah, so I'm Sheldon Cheskes. I'm medical director at Sunnybrook Center for Pre-Hospital Care in Toronto, Ontario, Canada. I am a scientist at Sunnybrook Research Institute, as well as St. Michael's Hospital in Toronto, Ontario, and an associate professor in emergency medicine at University of Toronto. So my major interest in my research career has been in the world of resuscitation. Most of my work has been in the area of CPR quality, STEMI care, some work in sepsis as well as CPAP, but the vast majority of my work has been in the area of CPR quality. This area in terms of refractory ventricular fibrillation has been an area that we've been interested here in Toronto for at least the last 3 to 4 years, culminating in the work of this first ever in the world randomized controlled trial on this particular topic. So we've been on many talk shows and interviews since the paper, the pilot study has come out. We're really happy to share our time with your group in terms of explaining some of the finer nuances of this particular research, particularly in comparison to previous research in the area. So we're just really happy to be here and really honored by the invitation. So with that, I'll give it to Ian Drennan.
Yeah, so my name's, as mentioned, it's Ian. I'm an advanced care paramedic. I work just north of Toronto in Ontario, Canada. I also work as a researcher and program manager at Sunnybrook Hospital and Sunnybrook Research Institute, and a paramedic educator at one of our local paramedic colleges in Ontario. So my research, I'm completing a PhD, pretty much done a PhD in resuscitation science, and the focus of my research is on clinical prediction rules and predicting or prognosticating patient outcomes after cardiac arrest or after out-of-hospital cardiac arrest. Some of my other research interests include looking at other clinical prediction rules as they relate to pre-hospital medicine, and I have a focus on a lot of time-sensitive conditions and time-sensitive treatments such as STEMI, cardiac arrests, and stroke in the pre-hospital setting.
Fantastic. It's really great to have you both here, people with such dedication to this type of research and to advancing EMS, and very interesting work. So I guess we should just dive in. as we kind of mentioned, this study's objective was actually to evaluate the feasibility for an RCT, randomized control trial, comparing a couple of different things. So I want to make sure that we highlight what these things were. We have vector change defibrillation and double sequential external defibrillation, and then that was being compared to standard defibrillation. So would one of you be able to tell us a little bit about what made you study these two interventions, and could you explain a little bit for our audience what the difference is between vector change and double sequential?
Yeah, so for me, I think this is a really, really important piece of the research that sets it apart from other research in the area. I think there's been many different thoughts about how double sequential external defibrillation potentially works. Is it because you're shocking through two defibrillators and therefore providing more energy? Is it that you're adding a different vector and therefore potentially defibrillating a greater proportion of the ventricle? Or is it related to impedance? And you can't really sort of sort that out without separating out vector change from double sequential. So the reason we went through 3 arms is we would be able to differentiate to some degree vector change, which is after 3, in this particular study, after 3 failed standard defibrillation attempts with the pads in the anterior lateral position, switching the pads to an AP position and then shocking in the AP position. So that pretty well discusses vector change, whereas double sequential is the sequential shocking by 2 defibrillators, the original defibrillator with the pads in the anterior lateral position, the second with the pads in the anterior posterior position. So the feeling was that if we could in fact find that there was a difference between these two, we could make some hypothesis as to is it vector or is it energy, and is there a benefit from one to the other? The other component that I think is very, very important, and when I lecture on this, and I've done this really around the world, there are many places where in fact 2 defibrillators may not be available for resuscitation. So if we were able to show that vector change defibrillation was superior to standard defibrillation, this would allow people to have different treatment in areas where 2 defibrillators were not available. So therefore, you're opening up a therapeutic strategy for perhaps BLS only areas. So I think it's quite important that we did this as a 3-arm study and be able to tease out that information as opposed to simply going with standard versus double sequential.
Absolutely. I think that this is one of the things that sets that study apart, is having those 3 arms, and really puts us in a good position to start to answer those questions that you laid forth. And I know that people are really going to want to talk about how the monitors worked and how the training happened and all of that. But I think it is important also to always talk a little bit about the study setting. So maybe you could tell us a little bit about the EMS systems that were involved with this work before we talk so much about the methods.
Yeah, so I think that's really important. So we used in the pilot study, there were 4 EMS agencies. So the Region of Peel, Region of Halton, City of Toronto, and the County of Simcoe. Mostly, other than County of Simcoe, these are urban settings. They deal with a fair number of cardiac arrests, up to 4,000 cardiac arrests per year. 25%, between 20 and 25% of them are VF providers. This is not, we're not a fire-based EMS system, so it's a system composed of both basic what we call primary care paramedics, which would be similar to the EMTs in the States, as well as advanced care paramedics, which are fully ALS trained. One benefit I think we had in our study is all the sites took part in 10 years of pre-hospital research in the Resuscitation Outcomes Consortium. And I think because of that, they were very comfortable in dealing with studies in terms of randomized controlled trials. They were comfortable in terms of working with cluster randomization, as many of our previous studies had used cluster randomization. So it was not a novel technique in terms of in terms of the paramedics understanding how the patients were going to be randomized. The other comment that I would make is, prior to the study beginning, many of these sites had been using double sequential external defibrillation for refractory VF, but never protocolized as it is in this particular study. It was only available through online medical control, and I can speak to that later in terms of why that change was in place. So I would say that these were very experienced EMS systems that had some experience in double sequential, but more importantly, had experience in taking part in randomized trials, which I think is really crucial to being able to carry off some of the research we did.
Right. It's important to have that support and buy-in from those who are going to be performing the work, and especially when we're trying to get high quality data collection. So I think that's really great that you used a group who was used to doing this kind of work. And now I know that Dr. Fernandez has a couple of questions about the method, so I'm going to go ahead and turn it over to him to ask a little bit about how it was that this study was set up and some of the analytical questions.
Thanks, Remley. And I think I want to just say to the authors again, thanks for joining us and great work on this study. I'm really happy we get to talk about this today. So this was a 3-arm pilot cluster randomized controlled trial with crossover. And this was conducted with, like we've talked about, 4 paramedic services located in Ontario, Canada. And the time frame was March 8th, 2018 to September 9th, 2019. Now, I don't want to run too quickly past the pilot cluster randomized control trial with crossover. We often have some budding researchers on the call, and I'd love if we can dive into this a little bit more and kind of pick apart what this actually means. So to the authors, if you can, we talked a little bit about this was a feasibility study and it was a pilot study. Can we dive a little bit deeper into how the clusters were formed and a little bit more about how they were randomized?
Yeah, so excellent question. So the clusters, when we're doing pre-hospital research, I think what you need to be able to do is do the research in a manner that's simple as possible for the paramedics. So randomization commonly can occur at the level of the patient, or it can occur at the level, as we did it, in relation to the service alone. So we considered each of the services as their own individual cluster. And what we did was we randomized the services based on their size and based on the frequency of cardiac arrest to rotate through the variety of different therapeutic regimens in a basis that would allow the number of patients to be the same in each cluster, which is common with cluster randomization. So in fact, when a site was randomly selected to take part in one of the arms, all the paramedics in that service provided that strategy for the 6-month time frame before they crossed over to a different therapeutic strategy. So everyone who was treated by the paramedics got that therapy. It wasn't, they didn't have to come to the patient and say, what are we randomized to today? What are we randomized to tomorrow? What is this patient going to get? Everyone got the same therapy. And I find from a pragmatic point of view, especially when you're looking at a feasibility study, this made a big difference in terms of the ability to stay within randomization and the paramedics' ability to stay within their therapeutic arm.
Absolutely, and thanks for diving into that a little deeper. So what you did here was you had each of the 2 treatment strategies were compared against the standard definition group, which was your typical defibrillation. And let's talk a little bit about your patient population. So you included all adults 18 years or over who remained in refractory VFib during non-traumatic out-of-hospital cardiac arrest of presumed cardiac etiology, and you excluded traumatic cardiac arrest patients, patients with pre-existing conditions or pre-existing do not resuscitate orders, and those suffering cardiac arrest secondary to drowning, hypothermia, hanging, or suspected drug overdose. I think those are some pretty wise exclusions. Do you want to comment on how you came to that patient population?
So I think these, to me, these are relatively standard exclusions for most resuscitation trials. You're really wanting to focus on patients who have a cardiac etiology. One thing that the classic sort of exclusions in the resuscitation outcomes consortium studies were peds prisoners, and pregnancy. So the one thing that was a little bit different in our study, we did exclude peds. Prisoners is not an exclusion in Canada, so they were allowed to be enrolled if that was the case. But pregnancy was a very interesting one. So pregnancy was not an exclusion in this trial. And the reason it wasn't was our original case report of success using the sequential was in a young 26-year-old female who was 1 month postpartum and was successfully resuscitated using double sequential external defibrillation. Our REB basically felt, based on that case alone, we should not exclude presumed pregnancy, and for that reason, those patients were not excluded. Not that we had any in the pilot, but I think people may wonder, was pregnancy included and why? It was a specific request by our research ethics board.
And Sheldon, can I just throw in there as well? I think one of the important things for the patient population, just to make sure that everybody is kind of on the same page, is that these were patients that presented in a shockable rhythm, so they presented in VF, and then for each subsequent rhythm analysis, they had to be in VF as well. So any patient that would have gone out of a shockable rhythm at any point during the first 3 analyses, they would have not been enrolled in the trial, which happened a little bit later on. So I think it's important that our definition for being in refractory VF was that these patients were maintained in a shockable rhythm and received a shock during the first 3 analyses.
Right, I think that is a really key point there. With defining refractory VFib in that way, you help eliminate a lot of what we see in some studies with resuscitation time bias, whereby the patients who actually get the intervention had a longer downtime, and then that could make the intervention look worse when in fact we don't know. But with this, you helped make the timing more similar between the different arms, is what I understood.
Oh my God, Remley, you just took the words out of one of our editorials we just wrote.
Oh, well,
like,
stole thunder.
It's essentially word for word, not true, Ian?
Yeah, no, it's a really important point. And this is, I think, one of the things you'd see a lot in cardiac arrest research in general is exactly what you just said, that everything gets biased by the fact that most of these treatments are very algorithmic and they occur in a very time sequential manner. And so by the time you get to these treatments, the patients that receive the treatments have had downtimes for a lot longer than patients that don't. And so, one of the big things that we were able to do here is try to control a bit for that and try and make this population a little bit more similar to each other than you see in a lot of other studies.
Absolutely, really important.
Absolutely. Thanks for clarifying that. I love these discussions. So we had you had 3 study arms. There was the standard defibrillation, and I'm sure everyone on the call is pretty familiar with that. Your second study arm was the vector change defibrillation group, and then you had the double sequential defibrillation group. Can you, just for those who may be newer on the call, can you talk about the difference between the vector change and the double sequential group? Just dive into that a little bit deeper.
Sure, 100%. I think what I'm going to do is sort of go through. We worked hours and hours on how to best protocolize this care, because we felt that the easier the paramedics could provide the intervention, the more likely the intervention was going to be successful. So basically, patients were included if they presented in VF and essentially went shock, shock, shock. So shock 1, 2 minutes of CPR, shock 2, 2 minutes of CPR, shock 3, 2 minutes of CPR. Then if they were after the 3rd shock, what we did was the paramedics did 30 compressions, 2 ventilations, and then if they were in the vector change arm, place the anterior pad of these new vector arm. They then did 30 compressions, 2 ventilations, and placed the posterior pad of the vector change arm. So now they had pads in the AA and AP position. They then did a full minute of CPR, and they hooked the transducer or the connector to the new AP cable, to the AP position, and provided 1 minute of CPR and then a shock at shock 4, which was now with the pads in the AP position. So it was very protocolized in terms of 30 compressions, 2 ventilations, anterior pad, 30 compressions, 2 ventilations, posterior pad, 1 full minute of CPR, and then the next shock took place with the pads in the AP position. When we went to double sequential, they did the exact same thing, but now the AP pads were attached to a second defibrillator. So you had new pads in the AP position, the original pads in the AP position, and then sequential shocking, not simultaneous, sequential shocking happened to the defibrillator by a paramedic pressing the shock button on 2 of the defibrillators now attached to the patient. We found by doing it this way, the paramedics had a standard mechanism by which they applied the defibrillator. They had a full minute of CPR prior to the shock, minimizing pre-shock pause, minimizing impact on chest compression fraction, and we found that the paramedics did the scenario quite beautifully in the pilot study.
And to do something as intricate and complicated as you just described, training is immensely important. And I think that you really hit the nail on the head with how you trained the paramedics that were participating in this study. So it looks like there was a combination of in-person training with some video and simulation learning. Can you discuss how these folks were trained?
Sure. So they would get usually an hour lecture on me in the area of refractory VF. They'd always get a talk on the particular study, and then we would run hands-on scenarios of patients in refractory VF where they got to practice both vector change and double sequential in the hands-on scenarios. One of the things in terms of these studies, many times when you have paramedics, to get them to buy into a research study, it's really important who trains them. And I show up for all the training myself. I find that paramedics buy in the most when they have the principal investigator teaching them. So I usually go to all the training sessions, and I find this has over the years really helped with compliance of the services, and the paramedics love generally seeing me there because they know if they have questions, they're going to get the answer, so to say, from the horse's mouth, as opposed to a coordinator or someone that you may not necessarily always know the answer. So our training is quite in-depth, and I think we prepared the paramedics well.
Yeah, and I'll add to that a little bit, Sheldon, too, that I think that the training was really focused around the choreography of doing it. Like Sheldon said, the most important things, I think, from a practical point of this, was maintaining that really high quality CPR throughout the 2 minutes where the change in protocol happened, and to minimize the shock or the hands-off time, especially around the shocks during that time. So our major focus was on trying to choreography to make sure that the medics were on the chest as much as possible, and then in the button pressing to ensure that we had that sequential button pressing on the 2 defibrillators as opposed to getting them at the exact same time.
And that actually brings that into account one of the audience members' questions. So we have Dr. Leggio who wanted to talk about that there were different monitors used. Was that something that you needed to control for, or was it something that was measured? So depending on the services, my guess, there may have been more than one model of monitor used.
Sure. So 3 of the services used Zoll monitors. County of Simcoe used a LifePak monitor. So in terms of energies provided, it would be different, obviously, from the shocking, but the education, the training was exactly the same, regardless of the monitors used.
Fantastic. So before we go into the results, and I know I'm holding us up from the interesting stuff, but I do think that it's important to talk about the type of study this was and why the first results that we're going to talk about have to do with feasibility and safety. So the the feasibility targets that you were looking at for the pilot study were successful delivery of the intervention in 80% of the eligible patients, as well as 80% of enrolled patients receiving intervention shock, which were the two comparison groups we talked about prior to the 6th shock. And then you had a safety measure that you looked at the outcome. So you looked at defibrillator damage as well as complaints of chest burns and concerns for paramedics and emergency department. Can we talk a little bit to the audience about how come we're not in this study just jumping into the juicy meat of which performed better, the VC or the DSED group compared to standard?
Yeah, so Tony, this is really important, okay? Most people kind of, in my mind, when I've done this talk, focus on the rates of ROSC, and that's the wow, but they don't focus on what we really wanted to accomplish, and that's to show feasibility. An internal pilot feasibility study, which is how we ran this study, has long been looked at in medicine and is really a critical portion of a trial. Many trials fall flat on their face because paramedics or any provider can't do the intervention the way you want them to do it. And when I first started in ROC, I was a co-chair of the study monitoring committee. We had some beautiful ivory tower protocols. The trouble was no one asked EMS if they can actually do them. And I think one of the issues in this particular study is there are many who would think that you can't actually do double sequential to this degree of precision out there in the field. And we wanted to show first, can you actually do this? Can paramedics be randomized? Can you collect outcomes? And these are things commonly studied in feasibility pilots that are rarely ever mentioned. So we wanted to make sure you could do the study before wasting lots of time on a randomized controlled trial that looks great on paper, but the paramedics would not be able to do it. So by setting feasibility outcomes, and we chose some of these in terms of the 80% numbers, based on a similar type of history of feasibility studies in the in-hospital environment. So 80% of patients receiving the treatment is randomized. The shock 6 one to us was very important. We had already published in Resuscitation approximately a year back work that suggested that early double sequential is better than late double sequential, and it goes to the comment that Remley's already made with respect to resuscitation time bias, a huge factor in previous observational work. So if we did a study and the paramedics got 30% of the patients shocked prior to shock 6, it's unlikely the intervention would be successful. So not only did we want to make sure that this could be done in the pre-hospital environment, we wanted to make sure it could be done well. And that's the reason why we did a feasibility study first as part of it. The key point is because these are relatively rare, we ran these as an internal pilot study. In those internal pilots, commonly the data is actually employed in the actual randomized trial, which is exactly what we're doing in this study. The idea about defibrillator damage and safety profile is, many of you know, there have been isolated case reports of defibrillator damage using double sequential. I can tell you right now, there has never been, in my experience, and no one's ever brought it to me, a case of double sequential causing damage to defibrillators when sequential shocking is used. With my EPS experts who work with me in this study, the only chance of damaging a defibrillator is simultaneous shocking when you get it to the exact millisecond. And if you do that, there is a chance of damage to the motherboard. But my paramedics are good. Getting it to the exact millisecond is incredibly rare. And we got around that potential by doing the shocks in a sequential manner, as quick as possible, but still sequential. And in all the years we've been doing double sequential, even prior to the study, we have never had any case of defibrillator damage, burns, or any of the issues mentioned in the feasibility slide.
I think this is so important to talk about, that a feasibility trial was conducted, often, you know, we want to rush right out and we worry about sample size calculations and making sure it's generalizable. But this makes me want to put on my quality improvement hat and say, you know, a lot can be gained in a feasibility trial. You have the opportunity to collect just enough data to inform the big trial and say, you know, we've learned some lessons along the way here, and we're confident that we've worked out all the kinks before we spend a lot more time and resources on the next study.
Yeah. So, and Ramley, I can tell you right now, one of the keys, and it's great that you're so well versed in feasibility studies. One of the key positions in a feasibility study is your ability to make adjustments for the ultimate randomized trial that you learn during the feasibility. So in our study, the number one finding or the number one issue in the pilot was we did not include fire shocks in the count of the 3 failed shocks. And lo and behold, those accounted for over 30% of the patients. So theoretically, if you think about it like this, if a patient presented and fire shocked the patient twice, and then the patient was randomized, so then they needed another 3 shocks, by the time they actually got the intervention, they were at shock 6. So our pilot feasibility study may have in fact underestimated the intervention effect by delaying the intervention through not counting the fire shocks. I can tell you we made that change in the randomized trial, and now in the randomized trial, 40% of patients have received fire shocks, but now the intervention in those patients is coming much earlier as we count those in the count of the 3 shocks. So it's really important these little small tweaks can make a big difference, and you can't learn that without doing a feasibility study.
Absolutely. And that sounds like a really important learning point, especially because a lot of services or a lot of systems may operate where, you know, first responders may administer that first shock, and then, you know, other things to consider in other systems might even be something like bystander administered shocks if it was in a public place and there happened to be an AED.
Yeah, 100%.
Yeah, it's a great point. And I think in general, for anyone that's looking to do research or any studies in the pre-hospital setting, this whole piece around feasibility becomes even more important just because every system is so different and the pre-hospital environment is so unique and in some cases chaotic that it's really important that you at least consider doing a feasibility piece where you can kind of work out some of these kinks or some of these unexpected events that may help to actually make your full trial even better than it could have been if you didn't do the feasibility piece.
It's just so important, and the import of this paper just can't be overstated just because of what it adds to your next trial. I just want those who are listening to take note of that. That's great. So I promise this is the last methods thing we'll talk about before we get to the interesting part, which is the results. But I do want to ask a little bit about your analysis and your analysis plan, particularly the intention to treat analysis, because I think that would be a great learning point for some of the folks on the call. So we can talk a little about why do an intention to treat in a randomized control trial, and then I think we can move on to those interesting methods we talked about, or results we talked about.
Ian, I'm going to bring the statistician in. There you go.
Okay, great, perfect. So when you do a randomized trial, you can have an intention to treat analysis or a per protocol analysis, and the intention to treat analysis is analyzing patients based on the study arm that they were randomized to, regardless of the intervention that they actually received. And the reason why it can be important to do this as your primary analysis is because when you randomize patients in a study, the randomization itself is there to control for some of the unknown or known confounders that can give you results that may not be accurate. And so when you randomize people, if you randomize people correctly, the idea is that you will control any of these extraneous variables that might have an impact on the outcome. And ideally, the study arms that you're comparing will then be similar in all of these other variables. And so you can then say that the difference between the outcomes is the result of your treatment. And so when you so if you were to do your primary analysis in a way that it doesn't take each of the patients that were randomized and keep them in their same randomization groups, then it can start to have an impact on the randomization itself and make the groups a little bit dissimilar and start to introduce a little bit of a confounding to it. And so it's important to look at the patients based on the group they were randomized to. And it's also important that when you can see it a little bit in this study, but it was actually done very well by the paramedics. But even though they may get randomized to a specific group, there may be some reason or some reason why the paramedics couldn't have kept them in that randomization group. So let's say they were randomized to double sequential. Perhaps even though they were randomized because they were in that cluster for that period of time, maybe they couldn't get a second defib to the scene in time. And so even though their randomization would have been for double sequential, there is a small number of patients that would have received standard treatment because that was our default if you couldn't stay in that randomization time. And so even though they were randomized to it, they actually got the intervention for one of the other arms. And so you would then do a subsequent analysis to look at patients that actually not necessarily what they were randomized to, but what treatment they received. And so you would analyze both ways, and ideally, what you'll see is that both of those will end up having the same result at the end of the day.
That was a really great summary of, what randomization is intended to do, and then the real world happens, right? And we don't always get to do what we were supposed to, but it is important to look at this in a variety of ways. And I think something important for the audience to recognize is that it's not pick your favorite method and the one that gave you the best p-value or the best results. It's presenting a complete analysis and looking at it in all of these ways, which the authors of this study did a really great job of doing.
Yeah, that's a fantastic point as well. It's definitely not let's pick which one gives us the results we were looking for.
And Remley, if I could add to that point, that was particularly one reason why we didn't randomize at the level of the patient. You could imagine if someone is randomized to standard care, or you had an envelope at the patient and it had standard care, and the paramedics wanted to provide double sequential. You could imagine what would happen at that patient level if we actually did it that way. So we eliminated that by using the cluster randomization, and we found it worked extremely well in our study.
Absolutely. I can see where cluster randomization and having, everybody on the same page could be really beneficial for a study like this. And then particularly because you did the crossover later, you're able to have people serve as their own controls within an agency, which I think is also important.
Yeah.
All right, well, let's dive into some of the results. I'd like to spend a little bit of time looking at table 1 first. And so in table 1, we were looking at, well, how did this pan out? We did the randomization, right? But how did the characteristics work out? So we can advance the slide. There we go. I'll let one of you walk us through, what do you see when we are talking about the demographic characteristics of the included population in each of the 3 arms? Is there anything there that we should be paying attention to?
Yeah, so to me in the demographics from the Epstein characteristics, really nothing much to see in terms of difference between the arms. The big thing though to notice is the rates of bystander CPR were extremely high in each of the arms. When I first started out here, our bystander CPR rate was 30%. To see 58% and 60% numbers, those are obviously really great numbers. Again, remember though, it's a VF subgroup, large number of bystander witness patients. So it's not that unexpected, but it was high. It was higher than what we thought we were going to see, but relatively well distributed amongst the 3 different arms.
So the randomization works. I think that's an important thing to see, is that, you don't have to randomize by patient. This actually came out pretty nice and even.
Yeah.
And now with regards to the percentage male, that seems awfully high to me. Is this something that we see with refractory VF, or was that surprising to you all? I see in one of the arms it was at like 92% and then 90%.
Yeah, that was high, and I think it's probably patient numbers. I suspect that'll that'll even out as time goes by. And that's, again, one of the tricky things when you're doing a pilot. You've got smaller numbers to deal with. I think that'll even out, but that's a very nice pickup that those numbers, certainly in the vector double sequential arms, were a bit higher than one would have expected.
Yeah, that makes a lot of sense. All right, well, let's take a look at table 2. So if we go to the next slide, and we'll take a look at some other characteristics by arm.
Yeah, so these are really our CPR quality ones. I assume, I don't know if I'm looking at the same slides, but to me, I'm really proud of CPR quality. I think one of the things that's been a huge knock against doing double sequential is you can't do it in a mechanism that minimizes pauses to rotate and log roll the patient. But look at our chest compression fraction in these patients. Look at our depth and rate. Look at the short shock pauses. Like CPR quality was all to benchmark guidelines, but equally in all the 3 arms. So you could not say that the results were as a result of differences in CPR quality. They all look very good in all the arms.
Yeah, and
I
that's,
think,
go ahead.
sorry,
Ian.
go ahead. Oh, I was going to say, I think the other interesting things to see on this table that I think are really important. I think the CPR quality is really important, like Sheldon mentioned, and to see that the CPR quality is fantastic across all 3 arms. And the second thing that this table gives a good description of is the different medications that were administered. And so something that always gets brought up is, were the antiarrhythmics and the epinephrine similar across the different groups? And you can see that there's no obvious differences in the percentage of patients that received amiodarone or percentage of patients that received epinephrine across these groups either, which I think is a really important point.
Absolutely. I think that monitoring CPR quality during this is a really important point, especially when it comes to things like we should be thinking of balancing measures. And so in any of the groups, did you notice any changes in like chest compression fraction or perishock pause, or was that something that you were looking for, particularly in the one where you have to switch the position of the pads?
Yeah, so you would think that if in fact there were long pauses to put the pads on, your chest compression fraction would suffer, but we don't see that here. Do you know what I'm saying? And I think this is a difference between an observational study and, in my eyes, a well-run randomized trial. Very few, if any, previous observational studies in this research have ever looked at CPR quality. Well, that's a big factor. Looking at doses of epinephrine, well, if someone's got a lot more epinephrine on board, they're going to be much more difficult to resuscitate than someone has fewer doses of epi on board. But you could see here, they were very evenly distributed between amio and epi in each of the different arms. So that, I think, gives us some comfort that our findings are not related to changes in medications or changes in CPR quality.
Yeah, and I think those changes, the lack of changes in CPR quality probably has a lot to do with the amount of time that you all spent on the training beforehand. So you mentioned that you had to work on the choreography of who does what and how do the pads get placed, and then what's the placement look like if they're in the DSED group versus the other groups. So I think that speaks highly of
I think that couldn't be more true, Emily. I think that's exactly what you see there, is that with really good training protocols and a lot of training for the paramedics, you can see that you can keep the CPR quality exactly the same across each of these interventions. And I think Sheldon mentioned a good point earlier that not only is the chest compression fraction the same, but where we had the pauses, because there are some very brief pauses that you need to get the other defib pads on, but where those pauses are is really important, and that we tried to make them as far away from the shock times as possible, because I think it's not only the number of pauses, but where those pauses are that could be really important. And you don't want to have pauses that make your pre-shock or post-shock pauses any longer. So I think that was another really important piece that we had.
Absolutely. And so I think that, even just table 2 is an important part of the feasibility analysis. And I would like to look at our feasibility outcomes. So if we go to the next slide, that's going to be figure 1. And we can talk about, what did you all see in terms of getting the treatment administered in time?
Hey, listen, they're well over 80%, so we were happy about that. Are you talking about the randomization one?
Yep, absolutely.
Yeah, so listen, 89.5% overall, 89% in double sequential. The reason they couldn't be randomized because the second defibrillator wasn't available at the scene for those small number of cases. Vector was a little bit higher, and this was a little bit tricky. What happened is we saw this actually initially in one of our sites, where the paramedics would provide the first 3 shocks. They would then move towards the vector change arm. And as they were moving to it, if they couldn't do it quickly enough, you'd come up to a 4th analysis and the pads were still in the standard position. They'd apply the shock and the patient the patient may have terminated VF, ending the possibility to get randomized in the vector arm. So we see this now in the randomized trial at a much lower rate, and certainly our overall compliance in the randomized trial is even well over 90%. So good learning. We realized the reasons why either double sequential or vector couldn't be done, and we actually focused particularly on the vector arm in ensuring that was done better as we move forward. So listen, overall, in EMS, those are good numbers.
I think those are just good numbers in general. That
Yeah.
the real world happens, right?
Yeah, 100%.
These are very good insights. And then another insight, if we move to the next slide and look at figure 2, this tells us about how many patients per month were getting enrolled into the study. And so this is an important piece too, because it talks about how long we're going to have to study this before we have enough data to make a reliable conclusion. So could you talk just a little bit about how hard it was to get the number of patients needed and how long you ended up measuring these patients for?
Yeah, so Remley, that's a fantastic point. So the study went from March of 2018 to September 2019. We wanted to make sure each site, the site started at different times. We wanted to make sure that each site had a full 6 months in one arm and a minimum of 3 months in one of the other arms. So even if they were randomized standard vector, randomized standard double sequential, they at least had a chance to do one of the intervention arms. The differences in cases per month relate to the frequency of refractory VF in each of these sites. So by knowing these numbers and then realizing in the RCT that we're actually adding another 2 services to our trial, we can actually establish good numbers with respect to what our sample size needed to be to have a statistically significant difference in what our end outcome, which is survival to hospital discharge in the randomized controlled trial. So this gave us an idea of study enrollment contemporaneously with the study, as opposed to going to historical values. So we felt that there's a much greater benefit of doing it at the same time, as opposed to looking at your historical rates.
Oh, the statistician in me is very happy to hear about that. So for those who aren't such stats nerds, it is really important to know or to have some information going in about what effect size you're planning to be able to see, because that affects how big of a sample you need. So if you have a larger effect size, you can use a smaller sample than you would if we were looking for a much smaller difference. And then another important thing that was probably gleaned from this is how much variability are we seeing between the different arms? And that again is something that would affect the sample size greatly. And so,
yeah, if we have time, I'll talk about effect size, because I think when you look at the outcomes in the ITT arm, that question has already come up.
Absolutely, and I do want to go to that. So if we go to the next slide, that's actually our next figure, and it has some of the results. So again, this was a feasibility study, but we have some insight into the outcomes of interest, and I would like to spend some time talking about those. So go ahead and tell us a little bit about what we saw in the arms just in this pilot study.
So very, very important. And when we responded to reviewers prior to publishing this, and Remley may have knowledge in this, many don't. When you run a pilot study, by definition, you're underpowered to make any statistical analysis. I think it's really important to do. You make a flow chart, as we've shown here, of your patients, but you should not read too much into the results from a statistical point of view. What we were able to determine here was certainly VF termination was greatest in the vector and double sequential arm compared to standard. ROSC at any time showed a 15% absolute difference in ROSC, and that actually held out to ROSC at ED arrival. People often ask, why did we look at ROSC at ED arrival? In my mind, I felt that that was much more closely going to be linked to survival to hospital discharge, which was our primary outcome in the randomized trial. So it would give us a bit of a sense to that for the randomized trial. And it tended to tell us that the vector arm, although getting close to the same rates of ROSC as a double sequential arm, seemed to have a higher level of rearrest. And we saw that because of a fairly marked drop-off at ROSC at ED arrival. Now, whether that pertains a perhaps lower survival to hospital discharge, we'll tell you when we link our data, but that's the reason for adding the ROSC at ED arrival. So if you look at these, there's not many things, and again, we're not going to get too carried away, but a 15% absolute difference is a large difference. And when you're looking at effect sizes, we've been already asked, can this affect how you run your study? Will you terminate your study early if this type of effect size continues? And one of the things that we've had in our consultation with our statisticians is stopping a trial for futility is well known. Stopping for benefit is a very dicey slope. And the reason for that, especially in cluster randomization, is there could be an inequity in the size of the arms, which overestimates the size of the intervention. And that's one of the reasons in general, you don't stop for benefit. I can tell you right now that in the randomized controlled trial, we've added another 95 patients, and that the effect sizes are even greater than what we're seeing right now. So we feel based on this, we're certainly on to something, and I'm just going to leave it at that. But Remley, you may want to sort of comment on that, on the effect size discussion.
Yeah, I think you've hit a lot of the important points that I wanted to make with this study, in that, you know, we don't necessarily need to be weighing in on this from a statistical perspective, but we can still glean some valuable information from a pilot study. And one of the points I wanted to make was that, you know, seeing some benefit here is really important, particularly when it comes to potentially securing funding for a future larger project, or Tony and I like to talk a lot about the IRB, and being able to show that the potential benefit outweighs the potential harms is really important when we're designing this kind of a study. I think we had another question from the audience I wanted to pull in. I'm scrolling and finding it here, but we talked about the outcomes that were picked here. Now, sometimes we have a lot of trouble linking hospital outcome data to the pre-hospital record. Is that something that you all are able to do? Is there a chance, either in this study or in the future, that you're able to see, you know, neurological outcomes at discharge?
Yeah, so Ian, do you want to take that? I feel like I'm doing a lot of talking. So you want?
That's fine. Yeah, no, I'll take that one, Sheldon. So one of the important parts about the actual feasibility study was actually our feasibility in being able to link outcomes before we moved on to the full RCT. And so one of the things that we were able to show with the feasibility piece is that we were able to use one of our hospital administrative data sets that we have on the Ontario-wide administrative data sets that we have. And we were able to link the outcomes for each one of our patients that were involved in this study. So we have the ability to link outcomes for each patient involved. Now, importantly, because these patients are subsequently being included in the full RCT, it's important that we don't look at the survival rates for the intervention arms and compare them to the standard arm, because then that becomes it becomes an interim analysis as opposed to just looking at a feasibility study. So we know we're able to link the data. We're able to get hospital outcome data for these patients, which is really important before we move on to our full RCT. But then at the same time, we aren't able to look at the survival data for the intervention arms. One of the other nice things that you're able to do when you do that is, and this just gets back to the effect size, is you are able to look at the standard ones and to see if the baseline survival rate that you had included in your initial protocol is what you're actually seeing in your study, which can speak to how many patients you have to enroll overall. And so what we were able to determine is that the baseline survival in only our one group was exactly what we had stated in our initial protocol. And so the sample size, we feel, is actually right on target with what we need to enroll to see an effect size overall. So a couple things that you're able to determine because of the feasibility piece is that we're able to get these outcomes, and that's going to be the main outcome for the full RCT, is looking at survival to discharge, but we just have to wait until we get the full RCT numbers before we're able to actually examine that outcome.
Oh, that's a great distinction. And it is wonderful that you're going to be able to look at that. It's often a challenge to link the records, and so it's something that we work very hard to do, and this will be very valuable data.
Yeah, so Remley, in our pilot study, we're able to link all 152 patients.
Well, yeah, and that's an important aspect of feasibility too, so that's wonderful.
Yeah, so we use CHI, we use NACRS, we use the registered persons database. Those are the administrative databases that we use to link these patients.
Excellent. All right, well, we are getting into the last 4 minutes, so I do want to make sure that we give chance to all the panelists to have any last thoughts. And I have one more participant question here. So I'm going to go ahead and turn it over and see, Bill Toon, do you have any final questions or thoughts for us? You've been uncharacteristically quiet.
I wanted to, well, first of all, I want to thank them for doing this. I think this is a very important work that needs to answer this question, because people want to know, does it matter? Does it make a difference? I do have two questions to ask, though. Was consideration given, and I'm not sure if it's part of your thing, to look at the placement of all the pads in the sense of having some kind of picture taken of pad placement and then having it evaluated later? For about 20 years, I ran a registry for a service, and one of the things we began to discover is that poor placement, standard placement, led to multiple defibrillations that were often corrected when someone came in and said, these pads are too close together. If we just move it more laterally, we do better. So I always wonder, and I've collected pictures over time showing poor pad placement, and wondered if that was ever taken as a consideration as a quality measure to make sure that the standard group truly has well-placed pads versus any of the alternative groups. That's my first question.
Yeah, Bill, fantastic question. No question, refractory VF couldn't be seen. Listen, I've seen people shock diverticulitis in my day. Okay, so the pad's down in the left lower quadrant, so I've seen it all. What I can tell you is these are services that have all taken part in many randomized controlled trials in resuscitation. The pad instruction was instruction in terms of putting the pads where the standard manufacturer pad placement was. I would suggest likely that, listen, we cannot rule out that a small number of patients may have had incorrect pad placement, but I think given the experience, given the instruction, I would suspect that it's likely quite small.
Okay, and then the other question relates to your thing about no damage to your devices. Out of curiosity, so are the devices that are used, particularly for the double sequential, do they end up being checked routinely by the manufacturer's biomedical personnel to assure that everything is functioning within its stated function? And again, this is just, I'm looking for things that makes the study, the results stronger. You know, you can be able to say unequivocally, not only did no one report anything, but the service records from the biomedical people show no damage to the devices.
I love that, Bill. That's a great question. What we got from both defibrillator companies, and believe me, defibrillator companies in general are not crazy about double sequential. And they're not crazy about it because they feel the risk of damage to the defibrillators. What they both instructed us was to do a self-test of the defibrillator after each use in double sequential. And that's what we did. We did self-tested defibrillator after each use in any arm, in any defibrillator that underwent double sequential, and there was no issues found, nor any reported by the logistics department of each of the services who also checked the defibrillators after use. So I think we can be fairly confident, given that history, that we weren't damaging any of the defibrillators.
Well, again, thank you very much. I look forward to the final thing, as well as I'm sure many other people internationally are looking forward to seeing your final paper on this beautiful feasibility study done. Thank you.
Thank you very much, Bill.
Absolutely. And I do want to get to the last audience question I have here, and this is from Jeffrey. And Jeffrey was asking about, it's clear that there was great training related to the resuscitation itself. Was there also training related to post-arrest care, since there were such high ROS rates?
Yeah, so that's what a great question. This is, are you guys going to bring me back for a second part of this?
I think we're going to have to, because there's just not enough time to get through all of this.
No, I just want to, before I answer the question, I just want to compliment you on really understanding the study. I've given so many talks on this on many podcasts. Never has anyone delved into the methodology, which really, when you look at these studies, the devil's in the details. And if you really don't appreciate the methodology in this study, you don't appreciate the study. And I really like to thank yourself and Tony and Bill for bringing up the methodology questions. They're critical to understanding what we're able to accomplish. With respect to post-resuscitation care, we did not do a lot of training other than our usual training in terms of post-resuscitation care. What I can tell you that again was a specific part of this study was that each of the medical directors overlooking these cases reviewed each case and gave feedback to each paramedic on the care provided in each and every case. Now, that's not normal. And that may not be generalizable to other sites, but it shows you the degree of buy-in by the paramedics and the medical directors who perform this particular study. So although we specifically did not give training to post-resuscitation care, we did give a lot of paramedic feedback on their overall care in each case in the study.
That's very important. We found that, feedback can be such a powerful tool. And I want to thank both you and Ian for letting us get so nerdy and really dive into the methodology. That is what we really love on this podcast. So definitely want to thank you again. And I am going to turn it to Tony for any last thoughts.
I just want to say again, congratulations on a well-written and really important study. And thanks for joining us today. This was great. Thank you again.
Oh, pleasure. Absolute pleasure. Remley, Tony, Bill, and your whole audience. Happy that people have my email address and they have Ian's address if you wish. Anyone has any questions that we couldn't get to today, be more than happy to respond to them.
Thank you so much. That is really important. And with that, sadly, we don't have another hour to go, so I am going to have to wrap us up, but we do hope to have you back with the full study soon. And so with that, we ask you all to remember to join us for the Education Research podcast that happens later this month. It's going to be on Friday, April 24th at 10 a.m. Pacific, noon Central. And we will be right back here with our clinical podcast the second Monday of the month. The next one's going to be May 11th. And thank you all again for listening. Look forward to being here with you next time. Stay safe.
Thank you.